This video will document the extended endonasal endoscopic resection of a pediatric craniopharyngioma done in an 8-year-old child who presented to the emergency room with some lethargy and visual loss. A large suprasellar solid cystic tumor was identified with significant edema in the hypothalamus. First, a standard endonasal endoscopic approach is performed with a bilateral superior posterior ethmoidectomy and sphenoidotomy. Bilateral nasal septal flaps were elevated to expose the ostium of the sphenoid sinus. The flaps were stored inferiorly in the nasopharynx. The sphenoid sinus was opened widely and the mucosa was completely removed. The large opening is required in order to make room for the endoscope as well as the instruments. A transtuberculum approach was performed with drilling of the top of the sella, since the tumor went down into the sella all the way down to the floor, as well as the tuberculum and a small amount of the planum extending just below the optic chiasm. The opening was performed laterally, just to the limits of the carotid artery. The dura was opened in a cruciate fashion. The tumor was immediately seen below the chiasm after opening the arachnoid. The suprahypophyseal arteries were swept laterally and superiorly to preserve the vascular supply to the optic chiasm. The tumor was mobilized laterally away from the arachnoid and dissected free inferiorly from the basilar tip as well as the posterior cerebral arteries. The inferior aspect of the tumor was somewhat invasive, slightly into the mammillary bodies, and this had to be carefully, sharply dissected free in order to preserve the mammillary bodies. Attention was turned to the superior aspect of the tumor, which was adherent to the hypothalamus. Additional internal decompression was done with the NICO, and under direct examination, a plane could be identified between the hypothalamic wall and the edge of the tumor. This was carefully, slowly, meticulously, and even sharply dissected free from the hypothalamus and the mammillary bodies to ensure a minimum of damage to the surrounding hypothalamus. The superior aspect of the tumor could be rolled out. The aqueduct of Sylvius is seen there, and then superiorly the fornices and anterior commissure can be identified. The superior aspect of the tumor is carefully mobilized and rolled forward with traction, counter-traction in order to avoid damaging the hypothalamus. The telechoroidea can be seen above, as well as the fornices, and the tumor is then completely removed. Some venous bleeding is stopped with thrombin-soaked gel foam. Examination superiorly reveals no evidence of residual tumor, and then the closure is performed with gasket seal using alloderm and Medpor. This is covered with a vascularized nasoseptal flap and adherus, as well as flow seal and Nasopor. The postoperative scan reveals a gross total resection of the tumor, and remarkably all the edema in the hypothalamus is gone.